Hi everyone, it's Annie Murphy. I'm a GP in Southwest London, and I'd just like to share with everybody a process map that I'd written about primary care access and some of the work that we've been doing to try and address the issues. Now, as you know, that public opinion on primary care has been decreasing over the years, with the demand in primary care being increasing, and this has been exacerbated during COVID with varying types of appointments on offer. And also coupled with a decline in GP numbers recently published in the Lancet paper, as well as BMA reports on reduction in GP numbers and increasing workload, with increasing GPs suffering from anxiety, burnout, and workload pressures. So there's been a need to look at primary care access and see and map out the patient journey through the access and see if there's any points that we can improve. So that's what I've been trying to do. So this is the overview of the process map, a very basic one through primary care, with the patient level and the interaction with the GP receptionist and call handlers, and then at clinician level, and then further services externally. So we focused a bit on the initial part of the patient journey. If somebody had a query or concern for themselves or their someone they're caring for, they would opt to contact the GP surgery either by telephone or walking in. Now, we did a patient survey recently, and just to look at what people prefer to do, and in our particular group of patients, the majority, over 80%, would want to phone or walk into the GP surgery. There's a minority that could go online and complete an online consultation or look at self-help services online. So once somebody calls in, they would be waiting for a receptionist to answer, and the receptionist would then book directly a telephone triage appointment with the GP. Now, this could be the potential pinch point, because if you had 5 receptionists answering the phone, all booking into one list for one GP, you can already see where the bottleneck will lie. Whereas this single GP would have to go through a very long list of people to triage and decide whether it's appropriate to bring in for face-to-face or to see other people or to see themselves. So we wonder whether this is potentially the pinch point that could be changed, because at this point, potentially with lack of awareness of other roles that's available, the receptionist might default to the GP. Whereas if the receptionist knew about the clinical pharmacists or physician's associates and what they do, then potentially they could divert through this path. So this is something we can talk about later, is what we're trying to do. Going further along the patient journey, once the GP has triaged the patient and decided if they needed signposting, they could then send the relevant info to self-referral, to MSK or mental health, for instance, or to self-help online. Alternatively, they could opt for a treatment or onwards referral and then close the loop that way. Again, at this point, it doesn't necessarily have to be the GP that does the onwards referral or signposting. If we were able to upskill reception staff to be able to do it at point, then that would potentially save a lot of time. There's always the loop back for the patient to come back into primary care in the same way if needed. So the other places that one can refer to would be the community sector. We've engaged with several different aspects of community, including social prescribers, health and wellbeing coaches, community pharmacy through the CPCS scheme, and community services and MDTs, as well as secondary care. So those are the options. There are other community services that I haven't mentioned here, which will need to be engaged and looked at, and there'll be dentistry, optometry, the voluntary sector, and many more. So overall, that's a snapshot view of the patient journey through primary care. There are a couple of biases in this general exercise at the moment, in that the patient population that we have surveyed are within one particular area of Southwest London that's slightly higher deprivation with a high representation of BAME, which meant that the majority preferred to access primary care services by telephone or walking in face to face. If we had run the survey in a different area, perhaps there may be slightly different results there. And then, as I mentioned, there are other stakeholders that could be included here, but for time purposes, I wasn't able to add them. So if we looked at the initial part of the pathway, this is the pinch point, potentially the bottleneck where that we can address. So the patient might wait for a few minutes or up to more than half an hour on the phone queue, just depending on how busy it is, the time of day, etc. And the receptionist would book everything by default into a GP's list. And if that was the case, then one GP dealing with, say, for instance, 50 to 70 calls a day, which isn't unusual in what we're seeing now, then there's bound to be a long wait before you get to speak to a GP. And by the time you do speak to a GP, probably by 7 or 8 in the evening, there may not be an appropriate face-to-face appointment available. So could we upskill our receptionists into patient navigators and allow them in a safe environment to work via a template that navigates, not necessarily triage, but there are certain things that usually will need a face-to-face consultation to make a safe judgment. Then if we have round all those up and have a template for our reception staff to be able to navigate patients and book patients into appropriate professionals for them, it doesn't have to be a GP, it could be a clinical pharmacist for a medication query, or an ANP or paramedic for acute queries, then we may be able to bypass this bottleneck and save time, energy and effort by balancing the workload amongst all the primary care staff instead of everything going straight to the GP in the first instance. So that potentially can improve the experience of care and the improved patient journey experience and overall improved staff experience because the workload is shared. So that's what we've been trying to look at through various working groups and engaging with all the different types of allied health professionals to see where their remit is and what they're comfortable seeing and etc. And then asking reception team what they think they can realistically do with the patient at point of access. So we don't really want the receptionist to say to the patient, there are no more appointments, please call back tomorrow. That's something we don't want to happen. We would like the receptionist to be able to work through a navigation template to be able to book the patient to the right health professional for their care at the right time and place. And it could be a pre-booked appointment, or it could be a same-day appointment. It could be a face-to-face appointment, or it could be a telephone appointment. It depends on the patient's needs, as well as taking into account the patient's wishes. So having engaged the various stakeholders and formed a working group, we've come up with what we call the hashtag GP SatNav, which is our navigation template. We have built this into EMIS, but there are potential, because it's a generic template, we can translate that into different systems if there is a need. So we co-designed this with patients through patient surveys and the PPG. We had on our working group members of reception and admin team, management team, clinical team, including GPs, ANPs, and allied health professionals as well. it was an audit-based design. We used telephony data, we used patient surveys and demand and outcomes data to understand what it is that people want during their encounters, and then built it iteratively over the course of 8 months to get to a template. And this is a continually changing template, and we edit it regularly based on needs. And the great thing about the template is, for instance, during when we have to comply with the IPC guidance, where we had to zone, we could change the template so that reception can just follow it and book according to the zones as needed. So it is flexible, and it can be user defined. So this is the what it looks like on EMIS. Effectively, this is the landing page where patients are asked certain red flags, which are pulled directly from 111 red flag algorithms, as well as some specific GP red flags. And then the template talks the patient navigator through how to fill it in. And all of it is coded so that we can then search later to understand the outcomes data. So with the homepage, there's a couple of mandated things, which are mainly the red flags that receptionists have to fill in, the COVID screening, and also the outcomes. So basically, this first page is the only mandated coded form, and that will help us in our searches later. On the other side, so if the patient has a red flag, it would talk them through. If it is a 999 type red flag, it would there is a necessary question where they have to offer an ambulance or a 999 call. If the patient doesn't have any red flags, then they'll move on to the alphabetical line on this side. So the symptoms are the most common presentations in primary care. I'm sure there'll be more, but effectively we've grouped them into most common. So we had the results and the pre-planned care work up on these two tabs, but after that it would be symptoms in alphabetical order to make navigation easier. And in the navigation, there are a couple of free text boxes for people to use, but essentially it talks people through what sort of thing that's most appropriate to book. And so at the end of each template, patients are asked whether they would prefer, if it's a routine call, whether patients would prefer a routine face-to-face or routine telephone. For the acute things, sometimes you just need to see them face-to-face, so we've just put them as emergency face-to-face. So those are your same-day access points. For certain place things as well, like minor ailments, we've also added the CPCS, the community pharmacy signposting option. So if they hit any of these, then it would trigger the protocol where we can then send the referral to community pharmacy. And this can be done by an upskilled patient navigator using this template. A red flag slot would be for a same-day urgent GP, and when you book a red flag slot, the patient navigator will alert the GP, and that will be a GP on call. So with these templates, we have associated protocols just for quick, easy access. For launching, and after that the template itself asks if you want to launch any other protocols like the community referral scheme. So potentially we can tag along things like social prescribing referrals or health and wellbeing coach referral protocols on top of that. Again, as I mentioned, dispositions can be changed and tailored according to practice needs and circumstance as well. So, certainly during winter pressures, we will need to change things slightly. We're planning to zone our waiting room. So again, that can be built into the template so that reception know what to say and what to do with certain presentations. And then finally, because we have a coded template, we can easily search for what we need to search for outcomes and to audit it accordingly. So effectively, that is the patient navigation template, the GP SatNav. We've been rolling it out at practice level, and it would be really great to work with anyone who's interested to maybe you can mold it into whatever you wish for your own practice. So please, if you're interested, please don't hesitate to contact me. I'm on Twitter as one here. And if you just hashtag SatNav, GP SatNav, I'm sure you'll find some of my other videos. Thank you for listening.